Afternoon.
Sorry.
Okay, I'll start again. Good afternoon, everybody. Thank you for coming to our webinar this afternoon on vaccines. And my name is Mary Saccone, and I'm the Director of Policy at Disability Rights New Jersey. I am also the project coordinator of our Administration of Community Living's COVID vaccine grant, which is funding this webinar today. Disability Rights is New Jersey's designated protection and advocacy system for individuals with disabilities. And so please check out our new website at disabilityrightsnj.org. I'm sorry, www.disabilityrightsnj.org to learn about us and our services. COVID vaccines have been authorized since December 2020, but there are still many individuals with disabilities who have not received a vaccine yet. Some individuals with disabilities are hesitant to get the vaccine because they have questions or concerns about them. Other individuals with disabilities have not gotten the vaccine due to barriers such as transportation or because they are homebound. Through this webinar, we are hoping to provide information to individuals with disabilities and their families to address their concerns, as well as address any barriers that they may be experiencing that prevent them from getting a vaccine. We've brought together 3 experts to help answer questions about the vaccine and how to address it. The first person I'd like to introduce is Dr. Amish Adalja. He is a senior scholar at Johns Hopkins Center for Health Security. He's an adjunct assistant professor at the Johns Hopkins Bloomberg School of Public Health and an affiliate of the Johns Hopkins Center for Global Health. His work is focused on emergent infectious disease, pandemic preparedness, and biosecurity. He has served on U.S. government panels tasked with developing guidelines for the treatment of plague, botulism, and anthrax in mass casualty settings, and for the system of care for infectious disease emergencies. During the COVID-19 pandemic, he has served as a member of the National Collegiate Athletic Association Coronavirus Advisory Group, a consultant to various businesses, schools, and organizations, and an informal advisor to the International Monetary Fund. Dr. Adalja is a fellow of Infectious Diseases Society of America, the American College of Physicians, and the American College of Emergency Physicians. He is a member of various medical societies, including the American Medical Association, the HIV Medicine Association, and the Society of Critical Care Medicine. He's a board-certified physician in internal medicine, emergency medicine, infectious diseases, and critical care medicine. Our second speaker is Dr. Vincent Silencio. He received his MD from Rutgers Robert Wood Johnson Medical School in 1991 and his Masters of Public Health from Rutgers School of Public Health. His graduate work focused on cross-cultural variation in models of HIV prevention and clinical care. He then completed a residency and fellowship training in family medicine at Thomas Jefferson University Hospital, where he continued his research on LGBT community health. His current work focuses on the use of social media and other sources of big data for LGBTQ mental health and well-being research, with a particular focus on suicide prevention research. He's currently a professor at the Department of Urban and Global Public Health at Robert Wood Johnson, at Rutgers University. And our third speaker today is Joe Galetta, who currently serves as the Director of Emergency Management for the New Jersey Department of Human Services. He is directly responsible for emergency management activities associated with the department's 7 facilities and 10,000 employees. He serves as the state of New Jersey's mass care, sheltering, feeding, reunification, distribution of emergency supplies lead during disaster response operations. He retired from the New Jersey State Police after 30 years of service and was leading New Jersey's Hurricane Sandy recovery effort along with our FEMA colleagues. Upon his retirement, he served as the executive director of the NJ211 Partnership, which is the statewide help and referral call center for those needing health and human services. I'd like to thank each of our speakers today. So to begin with, I'm going to start with Dr. Adalja.
Thank you for inviting me. Thank you for that introduction.
like Mary said, my name is Amish Adalja. I'm a senior scholar at the Johns Hopkins Center for Health Security, which is a think tank that focuses on infectious disease emergencies, pandemic preparedness, hospital preparedness, and I also practice infectious disease and critical care. So most of my work has been focused on understanding how new infectious diseases emerge, what their trajectory will be, how to prevent and prepare for them, as well as I have another role where I take care of patients that suffer from infectious diseases. So what I'm going to do in the next 10 minutes or so, maybe a little bit shorter, is kind of give you an overview of COVID-19, the virus that causes it, and where we are in the pandemic. And then my colleagues are going to kind of go into different aspects of it. But I'm going to try to give you a 10,000-foot level view of this from both a scientific perspective as well as a medical perspective. So let's rewind all the way back to December 31st, 2019. That's when there was a report that there was a respiratory virus spreading in China that looked like it was a novel coronavirus. And that was the report that went to the World Health Organization. So it's important to remember that COVID-19 is the disease caused by a coronavirus called SARS-CoV-2. And this is the 7th human coronavirus that we've discovered. And 4 of those other coronaviruses you've all had. 25% of our common colds are caused by those coronaviruses. So this was a viral family that we knew about. But there are some bad actors within that family. For example, the first SARS in 2003, which kind of circled the world, very disruptive, infected about 8,000 people and killed about 800. And you can remember if you saw deserted airports, Toronto getting inundated, just a lot of disruption that happened. And that really is what put coronaviruses on the map as something that could cause an infectious disease emergency. Now, fast forward to around 2012, another coronavirus called Middle East Respiratory Syndrome emerged in the Arabian Peninsula, places like Saudi Arabia, Jordan, Qatar, those areas. That is something that continues to occur. So that was another example of why coronaviruses became an important thing to look for. So that's why when China reported this to the WHO on December 31, a lot of alarm bells went off in certain countries, like Taiwan, for example, started preparing. So what do we know about this virus? So it comes from a family of viruses that we've dealt with before. And in what makes it different than the first SARS or Middle East Respiratory Syndrome is that it's much more transmissible from person to person. So once in China, it was established that this was spreading from person to person efficiently, that people were getting in contact with other people and getting infected, that it wasn't just somebody interacting with an animal or somebody interacting with the wet market. And you can ask me questions about the origin if you want at the end. This was something that had established itself in the human population. And when you're talking about a virus that spreads through the respiratory route, so that means through coughing and talking and laughing and spitting and all of that, and sneezing, it all becomes very, very difficult to control because it's so efficient, because you've got to breathe and talk and cough just as part of your daily life. And what we found out early on, we didn't know that people who had no symptoms at all, or didn't know they had symptoms, or were about to get symptoms, were contagious. That allowed the virus to spread very far and very vast before we even knew what happened. Because when a virus can spread from people who are asymptomatic or pre-symptomatic or with mild illnesses who are out and about going about their daily life, that makes it almost impossible, if not completely impossible, to contain. And that's basically the story of what happened. And the thing is about this coronavirus is that it causes a spectrum of illness. Many people, maybe over half, don't have any symptoms at all. Other people will have symptoms that are like common cold-like symptoms. But there are people that are at high risk for severe disease. Those people that are older, those people with other medical conditions like cardiovascular disease, like diabetes, like lung disease, immunocompromised people, people who are obese. And there's a list of those conditions. And what happened is those individuals were the ones that were most likely to get in trouble with COVID-19. Mild cases occurred in a lot of younger people, but this group of people that were at risk for severe disease was what was very, very concerning, because there's so many of them in the world. And countries like the United States, where the majority of people are actually overweight in the United States, and maybe 6% of the population has diabetes, were ripe for this virus to really hit them and then cause so many people with high-risk conditions to need hospitalizations that it could put hospitals in crisis. And that's what happened. early on in the pandemic. If you can remember back in March and in February, we had a very constrained ability to test. We couldn't know who was infected and who wasn't. Tests were only being done by state health labs. There was very strict criteria of who could order those tests and who they could be ordered on. And basically you had chains of transmission going on in this country. Now we know probably since December of 2019 that were bubbling over and putting hospitals in crisis in New York and in New Jersey and all over the country. And that's because there were so many high-risk individuals getting infected. We had no way to know who was infected and who wasn't. And I think Dr. Salenzo might talk about public health infrastructure. We have very poor public health infrastructure, so we couldn't contact trace or keep up with cases. So then you're in March of 2020, and governors don't know what to do. So they've got very blunt tools, and that's when you hear about these stay-at-home orders, why certain businesses were closed, because we kind of let the virus spiral out of control in January, February, half of March, when decisive action could have been taken, but we didn't have the tools to do it, nor the public health infrastructure. And a lot of the work that I do is about pandemic preparedness. And I can tell you that many of my colleagues have been screaming at people about this for decade after decade. And we've written report after report that likely is gathering dust in some drawer in Washington or in state capitals where people don't listen to them because they don't think it's something that can happen. But it did. And I think it's really important to remember that this was completely preventable if we would have acted decisively. Remember, Taiwan jumped into action December 31st, and they had like 8 deaths. They're in a little bit of trouble now because they don't have access to the vaccine because China is blocking their access to the vaccine. But throughout the pandemic, Taiwan never had to rely on any of those stay-at-home orders because they were able to meet cases as they came. We let a virus that spreads efficiently go for 2.5 months. And then we got the result that we got. And I think that's an important thing to remember as you talk to your legislators, as you talk to people at all levels, federal, state, and local, that pandemic preparedness is important, that we need to fund it sustainably. We can't have boom and bust cycles or panic and neglect where people don't fund these things when they're out of the headlines, because we cannot allow this to happen again. We're going to talk just a little bit about some of the treatments. So early on, so remember, the population, even though we've had other coronaviruses, there wasn't enough population immunity to this coronavirus, meaning that people were susceptible to it. Basically, the entire world was susceptible to it. So when people got infected, that came into contact with it, they got infected. And the ones that had severe disease would be hospitalized. And early on, we didn't have very many treatments at all. It was just supportive care. Eventually, though, we made some breakthroughs. One with a very common drug, dexamethasone, a steroid that many of you may have taken if you've had asthma or if you've had any kind of ordinary steroid actually works. But we found that in people who needed oxygen was really instrumental in giving them a better chance of survival. So throughout this pandemic, we've gotten better at treating these patients. We have dexamethasone, we have an antiviral called remdesivir that gets people out of the hospital faster. We've got fancy drugs that we can give people that decrease the inflammatory response, because when you get infected with any infectious disease, it's both what's infecting you and your reaction to it. So there's kind of 2 prongs of treatment, treating the virus part of it and treating your immune system's reaction to it. So we've gotten much better at doing that. And then, of course, we've not had anything for outpatients for some time. So people who got infected in the outpatient setting, they would get sick and they would come to the hospital. But we have developed new drugs called monoclonal antibodies, which are synthetic antibodies that we can give to people, so especially high-risk people. You wouldn't give it to a 20-year-old with no medical problems, but maybe you would give it to a 60-year-old who's not vaccinated and who has some high risk of needing hospitalization. You can infuse this antibody into them as an outpatient, and that might prevent them from getting ill. So we've got that tool as well. But by and large, what's really been the breakthrough is the vaccines. And I think this is going to end on just give you a little bit of updates on these vaccines. So going back to the stuff I said about SARS and MERS in the past, the other coronaviruses, that got people trying to develop vaccines for these coronaviruses, because we don't have coronavirus vaccines for humans for any of the other coronaviruses. And that work using new technologies that had been kind of burgeoning along for the last couple decades. So you might have heard of vaccine platform technologies or mRNA vaccines. These are basically ways to make vaccines in a whole different way that allows us to develop a candidate vaccine in basically days to months. BioNTech, which is the partner of Pfizer, they made their vaccine candidate in basically hours. Moderna, days, because all you need to know is what do you have to target on this virus and what is the genetic sequence, and you can print it off. And that, I think, is remarkable. So mRNA vaccines had been worked on for some time. Now they had a chance to shine. And the Pfizer and Moderna vaccines got emergency use approval in the United States, and really, and I think Dr. Salenziano will talk a little bit more about it, really changed the way that this virus is approached now, because by giving this vaccine to high-risk people, we've denied the virus its most vulnerable populations to infect, which then means we've allowed hospitals to kind of breathe easy, because if your high-risk population is fully vaccinated, nursing home residents, those with high-risk conditions, you're dealing with a much different virus. There's still going to be issues that you have. It's not going anywhere. It's going to establish itself in the human population, and we're going to be dealing with it 5 years from now, but it's going to be more like other respiratory viruses because of the vaccine. So I think that's really been the story of the pandemic, is the remarkable speed of vaccine availability. And it's not just the Moderna and Pfizer mRNA vaccines. The Johnson & Johnson vaccine also uses really great technology. It's a one-shot vaccine also that's highly efficacious, highly effective at preventing disease. And remember, our goal here is not to eradicate COVID-19. This is not a virus that can be eradicated or eliminated or that somehow disappears from the face of the earth. It's going to establish itself in the human population. Our goal is to deny it the ability to cause a public health emergency. And the way we do that is by vaccinating people, especially high-risk individuals who are most likely to need hospitalization. So that's the task in front of us. And I think we also have to use this pandemic as a way to advocate for better preparedness all across the board when it comes to public health threats, because this is not something that politicians who have very short timelines, they're only thinking about the next election, that they're going to think about. We've got to change that focus. And I think the general public has to demand better solutions here, because if you look at this pandemic in the United States, it's not the doctors that failed you. It's not public health that failed you. It's the government that failed you at the federal level, the state level, the local level, because they neglected this problem for so long. So I think that this is something you have to take forward with you to your legislators at every level, including even your little township supervisors. They need to think about this. So thank you for the opportunity to talk, and I'm happy to take questions afterwards, and I'm looking forward to my colleague's presentation.
Okay, thank you, Dr. Adalja. Next, we're going to hear from Dr. Salenzio. Thank you.
Thank you, Mary, and thank you, Dr. Adalja, because that was fantastic and also at warp speed. And I'm picking warp speed for a reason, right? So one of the really important points to think about this, it's pretty miraculous. We started 18 months ago knowing virtually nothing about any of these things that we've just heard discussed. We didn't know about this coronavirus existing. We didn't know these treatments would work. We didn't know how contagious it might be, how it might be caught and transmitted. We didn't know any of this. It's pretty amazing that we figured out in such a short period of time how to go about approaching this, right? Now, the flip side of that is you hear a lot of pushback from people saying, oh, I don't know about these vaccines, that, you know, these must be experimental. They just got developed like overnight. And it might look like that, right? It might be a little bit of a sleight of hand, but let me tell you a little story. There's a woman, she was a Hungarian immigrant, PhD, research scientist, came to the US in the 1980s, went to work at the University of Pennsylvania, at the medical school at the University of Pennsylvania, working on an obscure field of genetics and obscure corner of genetics research called mRNA. You probably recognize that because it's the name that's in two of our prominent vaccines, both Pfizer and Moderna. And this woman almost got drummed out of science because review sections at the National Institutes of Health would read her grant proposals and say, who cares about this crap? This isn't ever going to be important. This woman is crazy. Get her out of science. Don't fund her grants. And she literally was shown the door multiple times at the University of Pennsylvania because she was an unfunded researcher. And that's a no-no in the academic research world. But she would take no for an answer, wouldn't take no for an answer, wouldn't leave Penn, figured out ways to stick around being a research scientist attached to other people's labs, et cetera. Fast forward 20 years, the technology that she worked on is the basis for our mRNA vaccine. She is one of the principal folks for the Moderna vaccine that was developed. So what feels to you like it got invented overnight and maybe this is risky, blah, blah, blah. no, this work has actually been going on for quite a long time. So we have a lot of information about the safety, how effective they may be, what to look for to figure out if there was going to be a safety issue. So the first thing I want to say, just to underscore the point, is literally every possible thing has been done and is being done to assure that these things have been safely developed, safely implemented. We're watching them like crazy to figure out any even possibly tiny bits of side effects that they have. Also, because this is important science and teaches us about other things and may in fact lead to future cures and future kinds of vaccines, right? So I just want to put that out there and really kind of nip that one in the bud. These are not fly by night. These were just invented. These have got a lot of many years of development behind them. Dr. Adalja also mentioned the SARS and the MERS outbreaks from over 10 years ago through just under 10 years ago, and the technology to do the vaccines was actually first launched during that time. So the J&J type vaccines were actually developed at that time, but SARS did disappear right away. SARS disappeared right away. SARS won, but SARS-2, which you know is COVID, didn't. So what was the difference there? The difference was effective public health action. On the first bout of SARS and the breakout of MERS, the two things are related. They're coronavirus infections. In both of those cases, the infrastructure was able to jump on top of it in time before they could cause a problem. And the key reason that was possible, they weren't as catchy as COVID happens to be, as SARS-CoV-2 happens to be. So it's actually easier for me to have SARS-CoV-1 cough all over people and they not get sick than it is for SARS-CoV-2. SARS-CoV-2 is one in which people are very good at giving to one another. And you're probably hearing a lot in the news recently about this thing called a Delta variant, right? We changed recently the naming conventions so they wouldn't be so confusing. It was a lot of alphabet soup. So they just shifted to naming them after Greek letters to make it a little bit more memorable. So the Delta variant you hear a lot about because it, in fact, has been an even more infectious version of coronavirus than of COVID than the previous original form. And this is one of the reasons why we worry about it and why you still hear people saying that it is important, it is critically important to be vaccinated. When you nip an outbreak in the bud, like happened with the first SARS outbreak and the MERS outbreak, you actually prevent the thing from steamrolling on and getting established in the population. When we miss that opportunity to do that for COVID, we ended up having to do exactly the kinds of things that Dr. Adalja had talked about. Another old story, the word quarantine, right? Quarantine comes from an old Italian word meaning 40 days. When a ship would land in the end of the Middle Ages, beginning of the Renaissance at Venice, the Venetians didn't know how they were getting these diseases, but they knew if they forced these ships to sit on an island in the harbor for 40 days before they let anybody come into town, that they prevented outbreaks of diseases in the city. So this tells you how old this method is, right? This method is very, very ancient, but it's a cudgel. It really is a cudgel. It's a big hammer being used to hit sometimes a tiny nail. When you are in the middle of a initial outbreak, those kinds of methods are very effective at helping to keep things contained. But when things get so big and spread so far and so wide, even those methods may not be good at bringing things under control. And that's exactly why at various points we saw a second wave, a third wave of infections. These approaches are effective, but they're not perfect, and they're pretty crude, and they have been around for hundreds of years. Some of them have been around for hundreds of years. Others have been around for only about 100. One more point to underscore about how miraculous it is that we made as much advance as we did in the short period of time that we're talking about. there was another big pandemic in 1918 that I'm sure you've heard about by now, the flu pandemic from 1918. And that pandemic, we didn't know actually definitively even what caused it until 4 decades later. And we didn't actually figure out the sequence of the virus that caused that for 90 years, or practically 90 years following that. So we're talking about doing something in decades, in months, that it took us previously with all hands on deck, every scientist in the country and around the world working on it, took decades to figure out. So the capacity of our science, sorry, my dog actually wants to participate in this as well. So yeah, capacity of our scientific apparatus, our scientific infrastructure to be tilted at a problem like this is pretty awesome. That said, we should stop giving it so much awesome stuff to work on. And one of the ways in which you can really do that, and really that is important to underscore, is vaccination. When we get to this situation where the genie is out of the bottle, there is no getting the genie back into the bottle easily. And the only effective means, we can't do a lockdown for the rest of eternity, right? We can't all stay at home and never leave the house. We can't do that, right? So those methods at this stage are not going to solve the problem. But treating people effectively if they do happen to get infected, and keeping them from infecting others is very important. And preventing anybody from getting infected at all is extremely important. So one other thing that is incredibly important to underscore about how amazing the 18 months have been, these are also among the most effective vaccines we have ever seen, period. So we basically got to bring these new technologies to the real world and have been able to get results from them that were just very, very outstandingly, gobsmackingly, importantly effective. Now, they're not perfect. Nothing in life is perfect. They may not be as effective against one variant versus another variant, et cetera, but they are astonishingly effective. At this stage, in New Jersey as a whole, the country as a whole, with pockets both locally for us as well as nationally, where for all intents and purposes, the pandemic is running in reverse. It's starting to unwind because of the effectiveness of the vaccines. Where we're seeing continuing cases are among the unvaccinated. And so we, at this stage, still have an ongoing sort of simmering problem of COVID infections that occur in the background because we don't have enough people vaccinated to prevent that kind of simmering, that kind of smoldering embers in the background. So it's important to bring the vaccination rate up to a threshold that helps us to run the infections in general down to a lower level. Those are kind of the most important big points to make about this. I can answer specific questions about it when we do the question and answer portion, but the basic idea is why vaccination remains still so important, even at this point in time, where it looks like things might be, kind of going away. And in order for that to continue, we do have to achieve a higher rate of vaccination. And I'll give you a very simple way of thinking about this. Right now, we have a target of about 70% of the population for New Jersey to be vaccinated. What's that other 30%? That other 30% are people who actually could get COVID and could get severe COVID, can get all of the complications of COVID, so could be killed by it, could end up with long haul symptoms, et cetera. 30% of 8 million people is a lot of people. And so that's an important reminder that there are millions of people at whom there is still a tremendous amount of risk, and millions of people who continue to circulate in the real world, continue to interact with each other. So we have a large vulnerable population. If we stop at 70%, we have a lot of vulnerable people. And remember, there are sections around the country where that percentage is under 50%. And so still half the population are at a high risk of COVID. So just as a way of understanding, it's not that we are interested in trying to get a jab in every arm because, you know, we're some sort of crazy fixated people want to get a jab in every arm. It's because failure to do that leaves people vulnerable to infection. And one other reason that that's important, every single time COVID infects anyone, any human, any animal, and animal systems like minks, for instance, you may have heard the mink farms having to be culled, having to kill off all of the animals. Every time a person or an animal becomes infected, we are giving the SARS-CoV-2 the opportunity to mutate into a form that is potentially more harmful. Every single time, every single person gives the virus the opportunity to turn into something more horrific than it already is. And so if there's an argument to give to anybody you know who is reluctant about vaccination, it's the argument of, do you want to be the person in whom SARS-CoV-2 turns into a much more deadly disease and it's your fault? Do you want to be the person who's the petri dish that allows this thing to turn into something that is worse than it was before and can do more harm to other people? So even if it doesn't harm you, the chance of you harming other people inadvertently goes up. So it's you hear a lot about our trying to get everyone vaccinated. You hear a lot about these points primarily because of these concerns. We don't want there to be a large vulnerable population to become ill. And at the same time, we don't want a large population of people who could continue to help this virus get better at breaking through vaccines, finding a way to hit people who are otherwise resistant, et cetera. So the sooner that we get the rate of SARS simmering out there to go down to as close to zero as we can get it, the better we are for keeping it under wraps in the long haul. And I'll leave you off with one more little historical story. In 1918, the flu came out in the spring, killed virtually no one, made a lot of people sick, but not very many people died. It disappeared essentially during the summer, and it came back that fall. And that fall, it had already morphed into something much worse. And in that second wave is when it wiped out millions upon millions of people, tens of millions of people around the world. And so it's important to understand that you can almost think of it like a bad old vampire movie. Until you drive that wooden stake through its heart, the chance for the thing to come back, bite you on the neck, we'll keep it above the neck here. The chance for the monster to come back and bite you again is very, very high. And the potential is not a theoretical one. 1918 flu teaches us that when things come back to bite us the second time, they could be much worse than they were the first time around. And with that, I'll hop off here and stop yakking. So we'll take questions later on.
Thank you, Dr. Silenzio. All right, now I'm going to pass it over to Joe Galetta. Thank you.
Yeah, good afternoon, everyone. I want to thank Disability Rights New Jersey and, of course, my colleagues, Dr. Adalja and Dr. Silenzio, for great presentations. Just want to give an overview of the state's response to COVID. As was mentioned, I work for the Department of Human Services, Office of Emergency Management, but I work closely with the New Jersey State Police for the State Office of Emergency Management. There's only one other state that has the New Jersey or has the State Police Coordinate Emergency Management, and that's the state of Michigan. So the fact that the state police coordinates emergency management in this state is very beneficial because of the contacts and relationships we have with our communities across the state of New Jersey. So we work in coordination with Colonel Callahan He's responsible for developing the state's emergency operation plan. It's a pretty significant document broken up into 15 distinct sections labeled from emergency support function 1 through 15. Emergency support function 1 is transportation, 2 is communications, 3 is public works, 4 is firefighting, 5 is emergency management, and 6 is mass care and emergency assistance. Our Department of Human Services coordinates number 6, which is mass care and emergency assistance. So we're responsible for sheltering, feeding, distribution of emergency supplies, and family reunification during a disaster. ESF, or Emergency Support Function 8, is public health. So needless to say, with this crisis, this COVID-19 response, our Department of Health has been feverishly trying to engage many different communities to respond to COVID. We've been working very closely with the Department of Health, as well as many of our other state agencies, to try to support them in this endeavor. And it's truly been a marathon for all of us. I've been working in the State Emergency Operations Center, it seems sometimes 24/7. It's been very drawing on many of us. It's been a marathon, it really has. As opposed to a hurricane that we respond to, there's a start date and there's an end date. Well, we're still responding to COVID. Now we're focused on the vaccination efforts throughout the state. So it's been very trying for many of us, but again, we can't do this alone. We rely on partnerships across the board, from the federal level, state level, county, the non-governmental organizations, faith-based, community-based, volunteer organizations. There have been so many people helping us throughout this pandemic that really have made a difference to those most vulnerable in this state. I'm talking those with disability and access and functional needs. Our commissioner from the Department of Human Services, Carol Johnson, has moved on to the Biden administration. Now we are fortunate to have acting commissioner Sarah Edelman. Both of them have been very proactive with making sure we reach out to the most vulnerable of our state throughout this pandemic. Our department consists of a number of different divisions. Some of you probably have heard of. Division of Disability Services, Division of Developmental Disabilities, Division of Mental Health and Addiction Services, Division of Medical Assistance Health Services, Division of Deaf and Hard of Hearing, Division of Developmental Disability Services, Commission for the Blind and Visually Impaired. We've been working throughout all our divisions to make sure the most vulnerable of our state are protected throughout this pandemic. I'm talking doing wellness checks. I'm talking providing groceries when they need it. And more importantly, right now with this vaccination effort, trying to get the word out about how they can get the vaccination. It's been a never-ending task for us, but we're really committed to making sure the most vulnerable in our state are taken care of. Right now, we have a crisis counseling line. I mentioned how this has been truly a marathon for so many, and it wears on the mental health of those we serve, but more importantly, the first responders that have been really out there nonstop helping out. So this crisis counseling line is open Monday right through the week, 8 a.m. to 8 p.m. It's 866-202-HELP. There's also a texting feature. It's text NJ HOPE to 51684. I know thanks to the support of Disability Rights New Jersey, I put together a nice little document. It's a one-stop shop for all this information I'm going to share with you, so you don't have to go through the internet and start looking up stuff. Talks about everything you need to know about COVID, about vaccination, about where to get your vaccination, who can get vaccinated. I think it'll be very helpful that that's going to be shared with those that have participated in this webinar. Some things that we've been promoting in coordination with the Department of Health is information on vaccine locations. Most of you know there's been 6 mega sites set up that, in coordination with the state police, we've been supporting with ASL interpreters for those deaf and hard of hearing, and also other supporting entities to make sure people with access and functional needs are taken care of when they go to those mega sites. There's a rumor control hotline out there to try to dispel some of these concerns about the vaccination. Our Office of Homeland Security and Preparedness is putting a lot of information out on their website. That link will be included in the document that you'll be given by Disability Rights New Jersey. There is a homebound vaccination program that if you call a number, they can provide vaccinations to your home if you can't get to the mega sites. And the number is 855-568-0545. Again, this will all be in the sheet. There's also a number for seniors to call that may have an issue getting to vaccination sites as well, and that's 856-249-7007. Transportation to appointments, some are covered under Medicaid, and there's a number to call to find out if that's covered. If it's 866-527-9933. New Jersey Transit has a VaxRide program that if you want to somehow get linked into where the closest vaccination point is through New Jersey Transit, they'll provide that to you through newjerseytransit.com/vax, VAX ride. And you can see that on a map exactly where you have to go. New Jersey United Way has partnered with Lyft to provide free rides for those that need to be transported to vaccination locations. And through NJ211, you could get linked into that service as well. Lastly, New Jersey Department of Health has a Vax information page. It's called Vax Matters. A lot of good information on there. Try to dispel these rumors and concerns of people here to try to encourage everyone to get the vaccination. And also there's a New Jersey long-term care COVID resource page that's out there as well. So I tried to share that with the Disability Rights New Jersey team. Hopefully you'll have that available when they send the documents for this webinar, but it's a one-stop shop with all this information I provided to you. But just understand this, our Department of Human Services is still working at the state emergency operation in response to COVID. We're still ramping up. It's hurricane season. We got to be prepared for that as well. So thank you all for participating and for listening, and I look forward to working with you all in the future. Thank you, Mary.
Thank you, Joe. Before I start asking some questions, Denise, has anybody put any questions in the chat?
No.
Okay.
Not at this time.
Okay, well, one of my first questions is, a lot of people are concerned about, one of the things I said here is that, and this is to whoever wants to respond, the vaccines are currently only, they've received emergency use authorization versus FDA approval. And some people say, well, I'm not getting the vaccine until they get FDA approval. That means to me that they're not safe, or I'm still a guinea pig. Can you explain the difference between a emergency use authorization versus an FDA approval?
I'll take a stab at this first because we work on a lot of pandemic policy at my think tank. And so emergency use authorization is something that came about after the anthrax attacks, because we realized that in a public health emergency, we need people to be able to get vaccines, diagnostics, drugs faster than the usual process, which can be very slow in a public health emergency. So that's how this type of program originated. And it's not as if the COVID vaccines are the first things that have been available on emergency use authorization. Go back to 2009 in the H1N1 pandemic, we had certain antiviral drugs, one called Peramivir, which was available only on an emergency use authorization. So this isn't something new, but what it does recognize is that when there is a public health emergency, speed is of the essence. If we would have waited for vaccines to be fully approved, we would still have people dying at record numbers in the hospitals because we wouldn't have been able to vaccinate anybody. So the emergency use authorization is actually something that's really instrumental in being able to handle an infectious disease emergency. And it doesn't mean that the data was skimped on or anything. They still do everything the same. They still did phase 1, phase 2, phase 3 clinical trials. Indeed, many of us were saying faster, 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 because we knew how much we needed these vaccines. The FDA to approve a vaccine and give a full licensure requires 6 months of data post the last dose of vaccine. So that's just occurred in the last couple of months for Pfizer and Moderna. So I do suspect that you're going to see Pfizer and Moderna, who've both filed for full approval, get that in the next couple of weeks or so, hopefully sooner, because just for this reason, because we know that there are many hesitant people out there that are kind of hearing this about the emergency use authorization. Maybe they don't understand the history of that process and why it exists. But that's something that is normal. Remdesivir, initially available only on emergency use authorization. Those antibodies that I talked about that we're giving people, emergency use authorization. That's just a technique used to get things faster, and it does require safety and efficacy studies. And then, and many of these things go on to full licensure when the time period comes. So this isn't something to worry about with these vaccines.
And just to again bring it back to the fact that the science has advanced to the point that we don't have to use methods that we invented 500 years ago to try to combat an epidemic. FDA approval process was built for an earlier time when science moved slowly, when things couldn't be done quickly. And so what you will see as the years move forward is that it will essentially be a bit of a process of moving from the initial authorization use through a full approval and not be so confusing about this particular issue. As Dr. Adalja has said, absolutely all of the safety testing that is required for full approval is done. The reason that you have the 6-month piece is because it's actually a little bit of, okay, well, show us that it really continues to work after 6 months, right? So we didn't have the luxury of time to wait for those 6 months. So the emergency use piece can be a little confusing in that regard. It really is the same process. It has a slightly different name, and it was built for speed when it's an emergency and time is of the essence, but it does not cut corners on safety, not in the slightest.
Another question I have is that a lot of people don't know where to go get credible information. There's a lot of misinformation on the web. I mean, there's just a ton of information on the internet. And how do people know what is credible versus what is misinformation? Where can the person go to really get good, credible information?
I'll just start off by saying that sheet that I'm going to provide gives credible links, as well as connects people to those disinformation, misinformation links that are being reviewed by the Office of Homeland Security and Preparedness. So I think the links I'm providing in that sheet are the credible ones to find out current information regarding New Jersey's COVID response. It's usually from the Department of Health.
And probably the most reliable, albeit somewhat conservative and maybe a little bit slower than some of the things that'll hit the news cycle, will be both state health department as well as CDC, the Centers for Disease Control. I'll make a plug for Johns Hopkins because some pretty awesome resources are available across the Hopkins sites. So another absolutely fantastic source of information. But as Mary mentioned, there is a ton of wrong information, sometimes maliciously so, on the internet. And you do have to be careful of this. It's actually another area of research that I do. I work with folks in the tech industry around disinformation research. And so there are people putting a lot of effort into trying to figure out how to kind of not police this for you, but at least to help you understand, yeah, you're reading the site, but actually maybe this is a little bit of BS, or maybe this is actually a Russian troll who's trying to plant disinformation. So there are efforts to help you with this, but you do really have to be cautious. And even if you don't particularly trust the government in health functions, the health departments are very reliable, and probably your best first source of information. And like I said, there'll be a little lag because they are conservative. They won't put things up that aren't actually well established to share with you. But they are the most reliable resources.
Recently, I heard there was some articles that that the mRNA vaccines have some side effects for younger men with like myocarditis, I believe it is. Did I say that right? Did I say it right? Okay. And I know a few months ago there was a pause on the J&J vaccine because of it seemed to have this clotting issue. How safe are these vaccines, and how frequent do these side effects really appear?
So it's important to remember that every medicine we take, every vaccine we take has some level of side effect, and everything we do involves a risk benefit calculation. When it comes to the vaccines, they have a side effect profile, and some side effects are more serious than others. But when you look at the overall risk benefit ratio, meaning what are you preventing by getting the vaccine? What's the benefit to you of getting the vaccine? What is the risk of the vaccine? In almost every situation, the vaccine comes out on top. And that's the important thing to remember, is that there's always going to be this risk that's pretty minor. And I think you have to take into context, we're still in a pandemic. There are hundreds of people dying every day, and the vaccine offers you protection against that. So this is a risk that I think is highly outweighed by the benefits that the vaccine offers you. So going to the specific side effects. So the Johnson & Johnson vaccine, there have been some reports, pretty rare, probably less than one in a million, or maybe a little bit more than that, of a rare blood clotting disorder that occurred in certain individuals, tends to be women of reproductive age. This is something that was flagged early on. They had an 11-day pause, which I sort of disagreed with because I think it increased a lot of vaccine hesitancy. And what we now know is that this is something that we have to look out for. So we can diagnose it, we can treat it, we can counsel people on it. And we have alternative vaccines if someone is very worried about that condition. But even if you look at it, the risk-benefit ratio still favors the Johnson & Johnson vaccine, especially since it's a single-dose vaccine that you can get to hard-to-reach populations because it doesn't require special cold storage. The Moderna and Pfizer vaccines, there have been some reports lately looking at something called myocarditis, which is inflammation of the heart. This is something that happens with other vaccines. This is something that happens with viruses. This is something that COVID-19 itself causes. What we know about these myocarditis cases is it seems to be in young males that are getting vaccinated. So teens to maybe early 20s or so is where this is happening. Most of these cases are mild, meaning that people recover with no problem. A lot of them get hospitalized because anytime you're dealing with something with the heart, people kind of err on the side of caution and hospitalize people. But this seems to be very different than other cases of myocarditis, meaning that it's very, very mild. So this is something, again, you have to do a risk-benefit calculation. And you might say, I'm an 18-year-old male, I can get the Johnson & Johnson vaccine then instead. So there is a menu here to be able to mitigate these risks. I think the risk-benefit ratio still favors the vaccine, even with that myocarditis risk, although there are some people who are saying maybe we delay the second dose. If that's the case, in young males, delay it, maybe you'll get less of it. There's a lot of hypotheses being pushed around there, trying to figure out what's best to do it. But I think this is a manageable side effect and not something that I think really overall changes the risk-benefit ratio. But again, if you're a male above 18 and you're worried about that risk, the Johnson & Johnson vaccine is an option for you. So just remember that there's ways to get around these risks, and nothing is going to be risk-free. And we're still in a pandemic, and the risk-benefit ratio still favors the vaccines.
And only one additional point to underscore, which is both of those side effects, as well as others, occur more frequently with the virus infection itself. So if you get COVID, you are more likely to have a myocarditis and more likely to have the clotting dysfunction than you are with the vaccine. So it is important to understand that these are in part because of the way that the virus itself is bringing about these complications, and that the vaccines are related to the virus in a way that the same complications could be seen, but they're occurring at a much lower rate. And there's evidence, strong evidence now to show that folks who have got the so-called long haul COVID symptoms, people who recover from COVID infection but still have all of the side effects left over, that their symptoms improve once they are vaccinated. And so again, the mechanisms are, it's not important to kind of get a PhD in understanding the mechanisms. The important point is that these are potential risks, but the risk from COVID itself is greater. And so if given the choice between getting COVID itself versus getting the vaccine, it's a no-brainer.
So we actually did have one question in the chat box. I'm going to chime in here for one moment. So they asked if someone was homebound and they have an aide, are they both able to be vaccinated in the home? And Mr. Galetta actually answered that for us. And mentioned that if an appointment is set up for a homebound person, then the homebound person and their aide can be vaccinated at the home. Thank you for that answer.
Right now, one of the largest groups of people who aren't vaccinated are obviously children under 12 because they're not eligible to receive the vaccine. And I understand that some have, they're undergoing clinical tests. When do you think that when do you think they will likely get approval for that, especially when you consider kids going back to school in the fall? And one of the big concerns, especially for children with disabilities who have issues with wearing masks and things like that, that can be a real issue for them.
So right now, the studies are going on with both the Pfizer and Moderna vaccines in the younger age groups. And this again goes back to risk-benefit ratios. We want to make sure that this is a safe and effective vaccine, and it's worth it for children because as you get to younger children, they're less likely to have severe disease. They're less likely to spread the infection. So you want to do a new study to say, does this make sense in this age group, especially as more and more adults and more people above the age of 12 get vaccinated, prevalence goes down. So it's a different risk-benefit ratio. So that's what's going on. It's likely going to be a lower dose that they're going to recommend as well for younger kids. So that's all going to be worked out. I think people think probably around Thanksgiving is what we're looking for. That may change over time, but that's the best estimate that I've seen. But again, I think that it's not complete. When it comes to children, if you're not dealing with a child that has asthma or some medical condition, I think that we've lucked out with this virus that it's not that dangerous to them, relatively speaking, compared to other respiratory viruses that they face. So a lot of this is going to boil down to a parent's risk tolerance and the individual risk factors for severe disease that child has. It's not going to be one size fits all. I think getting the vaccine is going to be an option for many parents, and it'll make that decision a lot easier. But I don't think that we should necessarily hold back children less than 12 from engaging in the world because of the lack of vaccination status. With the caveat, if they're a high-risk child, you have to be careful because we know that children kind of suffered psychosocially throughout this pandemic greatly. And a lot of that is not because of the disease or the virus, but because of parents and the way that and the risk perceptions. So I think that's just how I come down on the view of vaccinating less than the age 12. And again, the WHO and many countries are not vaccinating children because of that, because the risk is much lower to them of severe disease, and they see the risk-benefit ratio differently.
Another question I have is obviously no, as Dr. Silencio said, there's no vaccine that's perfect, and there is a good, and as the vaccines or as the virus mutates, there's a greater risk that maybe the vaccines won't be as effective and you can get COVID. If I could get COVID even with the vaccine, what's the point of getting the vaccine? Some people ask that question.
Right, because it's actually theoretical that you might be able to get COVID later. It's not that you're going to get COVID later by any stretch. In fact, the experience so far has been pretty impressive with how effective the vaccines continue to be against the variants that we've seen in play. In some places with some vaccines, remember, the US is not the only place that in the world that has developed vaccines. There are quite a number of vaccines that have been developed around the world. The ones that are deployed here and approved here have proven to be very effective against variants of COVID as well. The reason that I bring that point up, though, about the risk of this developing later is exactly the reason you have to get vaccinated, because by not getting vaccinated, that's where we're throwing the dice here and trying our luck. It's a little bit, I hate to keep mixing metaphors, but it's a little bit like Russian roulette, and you do not need to keep pulling the trigger. So the risk is an unnecessary risk to take by remaining unvaccinated.
I just had one thing and then I have to go. But I would say, so the breakthrough infections that occur in fully vaccinated people are the exception. It's 99.99 something. That's the rate of breakthrough. That's the rate of protection. So it's 0.000 something for breakthrough infections. And the breakthrough infections that are clinically significant are even lower than that. So when we see these breakthrough infections, they don't really mean anything from a clinical perspective because the viral load is very low. So you're not going to get very many symptoms. You're not going to be very contagious to other people. So these vaccines are as Dr. Salenzo said earlier, some of the most effective vaccines that humans have ever invented. So the fact that it's not, people aren't getting COVID after the vaccines. I mean, it's the press that's sort of focusing on the 0.001 because that's kind of the man bites dog story. These vaccines are highly, highly effective. Again, I have to run, but thank you for the opportunity, and feel free to email me or get in touch with me if you have questions. You can find me on Twitter.
Thank you for coming. I really appreciate it.
All right, bye.
Mr. Salenzio, did you want to say one more thing before we finish?
Well, I want to thank Joe Galetta, because these are exactly the points, Joe, that I would have forgotten to mention. Right, the state has done a fantastic job of trying to make sure that you have access and to take care of the population. So as Dr. Adal just said, we have lots of things to lay at the feet of some of our elected leaders for how the pandemic rolled out. No question. Nobody is perfect either, right? But really, we've done a really impressive job in the state, in New Jersey. Our folks really deserve a big hand for having been as effective as they have been in responding to this. It took us a while to realize just how awful the problem was in the state, but once that realization hit, it has been nothing but incredibly well managed, well meant, well thought out response. And it's because of folks like Mr. Galetta. So I just want to say thank you, Joe, for that.
And we actually had a couple comments in the chat. One is, if someone has or had COVID, how long does the individual have to wait to get the vaccine? If Dr. Salenzio, if you would mind answering that one.
That's an easy one, because we could say, well, remember, this has all been developing very quickly. So the best guess for this is actually people can receive the vaccine right away. We still advise most people to wait until their symptoms, COVID symptoms, are kind of gone. But remember, I mentioned there are long haulers, some people for whom the symptoms don't go away, but typically within that couple of weeks' time, people recover and their symptoms have largely gone away. So we typically encourage folks to wait until that point. We do know that the infection gives you some temporary immunity. And so it looks like that temporary immunity might last for a couple or 3 months. And so we do say for folks to make sure that they do get vaccinated at least by 90 days later, because we want to make sure that you don't get reinfected. We know that vaccines are great at preventing reinfection. We know COVID itself is not. And so we recommend to make sure that you wait until the symptoms are done. So generally sometime around 14 to 28 days after the whole process is and then the outer limit of that being 90 days. Obviously my dog has an opinion on this one too. So.
Great, and I think we're actually at past time, but Mary?
Yeah, are there any other questions before, as we say, we'll wrap this up?
Yes, there's one. I just, so I have spoken to several well-informed people who have cited studies from around the world, including Israel, Brazil, Italy, South Korea. Much of the information they have discussed with me is published by the NIH, medical journals, etc. The instructions for fighting off COVID-19 appears to be in your bone marrow after recovery from COVID. Why should they get the vaccine?
For exactly the point I just said, which is those instructions don't seem to work real well after 90 days. So if you want to get COVID again, all more power to you. But if you want to prevent getting COVID again, if you want to actually make sure that the instructions that you do have, it's not quite in your bone marrow, but I get your point. I'm not going to quibble about that. That's kind of silly. That you're generally right that you do. That's what is called immunity, and so you do get immunity, but it wanes very quickly after COVID infection, meaning that your chance of getting it again is very high again after the 3 months time. And so the way to prevent getting it again is to have immunization.
Thank you.
Okay, well, thank you, Dr. Silenzio. Thank you, Joe Galetta, for participating. I think this was very informative. I hope we were able to answer people's questions and address some of people's concerns regarding the the current vaccines. So I really appreciate you both taking the time. Mr. Galetta will have his form and we will send that out to everybody so that everybody can have that information as well. Thank you again. And if you have any questions, you can feel free to reach out to me, reach out to Disability Rights New Jersey, and please go into our new website at www.disabilityrightsnj.org. Thank you again.
Thank you, guys. Have a good one.
Thank you.